Good afternoon, everybody. Welcome to the launch for the ERC and AHA BLS guidelines. It's my pleasure to be here. Hopefully you've managed to access those and had sight of those. If you haven't, we're going to go through some of the areas of the guidelines where there's difference between the two guidelines, where we have sort of a large amount of agreement and new emphasis in the guidelines, and we're going to discuss some of the topical areas within the guidelines. Technically, I'm supposed to be Janet Bray. The more astute of you will notice that I'm probably not Janet, so I'm standing in for her. She's unable to be with us today, but we wish her well. I'll be trying to challenge my inner Janet and not to make any sort of make her proud in terms of what we've done. I'd like to acknowledge the amount of work that she's put into getting us to this point in terms of the underpinning evidence. So the things that we are going to be doing today. Just to make you aware, there is a online Slido platform for those of you who are joining online. You can ask questions. We are limited to the amount of questions that we can ask, so please don't sort of introduce yourself and use up those questions, and just use them for your particular question. So like I say, we have a limit of 200. I'd be surprised if we managed to answer 200 questions from an online audience, but hopefully many people will have the same question, and those will be filtered, and we'll address those at the end. In terms of the content about what we're going to look at today, we are going to look at an overview of the ILCOR process, how we actually get to the point where we are making recommendations. We're going to look at the differences between the guidelines themselves. We're going to look at the hot topics that we think where people may have an interest in terms of particular things that have changed within the guidelines. And then we're going to look at some of the research gaps where we think we still need more evidence. So talking to the ILCOR process, it was alluded to in the previous session, just to kind of give you an understanding. We start off with a question. Now that question may be one that has been in existence for a while, for example, how far should we undertake chest compressions? But it may well be a new question, such as, should we use airway devices to clear the airway? So we will look at, if there is an existing question, do we need to modify it? So have outcomes changed at all? And equally, if there is no question, we'll have to develop a new question. Off the back of that, or rather feeding into that, we need to decide, are we looking at a systematic review or a scoping review? And then we develop the search question. And it may well be that if we're doing a systematic review, that we register that question on the Prospero website as well. Once we've actually run the search, we then have to go through and screen the titles and the abstracts. We then go through the full text, we extract the relevant data, and depending on whether or not we're doing a systematic review or a scoping review, we'll undertake a risk of bias assessment, and then we'll undertake the sort of the formal grade process to merge that data together. Once we've got the data, we then use that data to make recommendations, and the way we go from data to a recommendation is to use what we call an evidence to decision table. And it's the evidence to decision table that takes into account things like resources. So it's pointless us making a recommendation that, for example, every patient should be taken to a hospital to avail them of the opportunities of ECPR. But if the hospital doesn't offer ECPR, making that recommendation is pretty pointless. So from that, we then make the treatment recommendations and potentially good practice statements depending on what the evidence has shown and which type of review we're doing. And then that goes back to the task force for discussion. Once we're all happy with what we've said, that goes out to public comment. We may make adjustments based upon that, and essentially the co-star is finalised. That co-star is then published widely, and it's those co-stars that many of the task forces use to write their guidelines. So in terms of writing the guidelines, I was the individual who kind of had the good fortune to lead the writing group along with my colleague Sunder, who sat up front. There was a group of 13 of us, unlucky for some, but we were a diverse group in terms of from different regions of the world, different levels of experience, some from an educational background, some from a more scientific background with guideline experience. Of particular note that we were very fortunate in terms of the ERC. We also had a cardiac arrest survivor on our writing group, Mr. Wolfgang Keck. He's the gentleman who's towards the centre, wearing the blue t-shirt with a lovely background and wearing sunglasses. Alongside that, we had a senior mentor who was Gavin Perkins, who oversaw what we were doing. We were very ably supported by Marley from the ERC staff, and we had the opportunity to share our first draft with the ERC's Basic Life Support Science and Education Committee. So they provide an element of peer review and sense check before we went out to wider publication. In terms of what we did, the scope of our document, our target audience, although we are aware that BLS guidelines are applicable to both lay personnel and healthcare professionals, we wrote this guidance specifically targeting lay people rather than healthcare professionals. So that was our primary audience, and as a consequence of that, we modified the language that we used somewhat, but we're also aware that it would be referred to by healthcare professionals. So we have the evidence linked within that. We've just changed the way we phrase the evidence recommendations within the guideline to make it slightly more accessible. The sort of timeline in terms of development, we started in the beginning of January 2024. We looked at what was in the existing guidelines. We had an awareness of what was coming out of the BLS task force from ILCOR, and we made the assessment. We had to decide, did we need to undertake any additional reviews alongside that? So the period from January to December 24 was relatively quiet because we didn't think we needed to undertake any extensive additional work to identify other areas of research. Come January, however, all bets were off. The ILCOR Consensus of Science and Treatment Recommendations were made available to the task force, and writing in earnest started in January. By the end of sort of March, beginning of April, the guideline was largely drafted, and it was at that point that it started to go through the initial checks internally within ERC, then going out to public comment in June, finalised sort of late June, and then going to the publishers a short while ago to where we are now. So in terms of the scope, we all worked in terms of a mock chapter template for the ERC guidelines. We had a basic introduction, we had key messages, and those are kind of the key take-home messages. We had the algorithm. Then we had in our guideline a concise guideline, which are the individual steps to be taken, but they didn't have any evidence underpinning them. So it was just do this, do that, and this is how you do it. And beyond that, we then had the evidence informing the guideline. So we essentially repeated that step, but we then added all of the all of the evidence that informed those particular steps of the guideline. Just to make everybody aware, in terms of the ERC guideline, ILCOR uses the grade methodology. We, within the ERC, also use the grade methodology. We like to stay consistent with that. But as I said previously, we made a conscious effort to try and simplify how recommendations are worded. So within grade, we use the certainty of evidence being high certainty, moderate certainty, low certainty, or very low certainty. And then we have a strength of recommendation, which is either going to be strong or weak. And it can be changing the word, so strong is recommend, or rather the word that we use to demonstrate a strong recommendation would be recommend. And sometimes that language can get quite technical. So we tried to simplify that to make it more accessible to lay readers. However, it's important to note that all of the evidence is linked within that. Apologies, I've actually gone. So that's the slide that I was meant to say in terms of talking about the evidence. So I apologise for that. You can see the evidence, the process there. If you're interested in this process, there is also the chapter on methodology, which will give you much more detail in terms of how that works. So I'm going to hand over now just to see if somebody wants to talk through the sort of the philosophy behind developing the AHA guideline. Do you want to? No?
Thank you. Good afternoon. I guess my timing was pretty good. I apologize for being late. Happy to talk about the process of the AHA Basic Life Support Writing Group. This is a picture of some of our members. And you can see Tatsuo was one of our incredibly productive members of this group, but really what I'm presenting is on behalf of all of these folks who were just terrific to work with. One of the things to point out about our scope and the process of our development is that we really were trying to look at the spectrum of care for basic life support. And so we did cover everything from lay rescuers who were trained or untrained to healthcare providers in both the out-of-hospital and in-hospital setting, recognizing that there are trained lay rescuers in the out-of-hospital setting as well as in-hospital. And so this was intended to really cross the continuum of all of these settings, even though there are potential differences in the experience, training, resources. BLS is still BLS, and chest compression quality is still chest compression quality. And so some of the differences being about willingness to do ventilation or whether or not you have an advanced airway, we still looked at BLS as something that really crossed the continuum of care. You've already heard about the way in which the guidelines are developed. We did this over about a 3-year period of time with a lot of phone meetings, a lot of discussions by email, and then some in-person meetings. But the standard way in which these were then condensed into actual recommendations was the use of the term knowledge chunk. And this was introduced in 2020 as the way in which the guidelines would be illustrated in the text. Essentially, it's a box of recommendations, which gives the title in the red box at the top, and then gives the very specific recommendations with accompanying text of a synopsis, and then what we called the recommendation-specific supportive text. So by recommendation, so one, in the case of this one, there were 5 different sets of recommendation-supported text. The other thing that is noted in this is that we indicate for each recommendation a class of recommendation and a level of evidence. This is also not a new process. This is what has been done for many years, but it's really intended to be transparent about the strength of the literature and evidence supporting, as well as the quality of the evidence. And so just to break that down into something that's a little bit more digestible, the class of recommendation really is the strength of the recommendation. And so it is a benefit-risk type of comparison. If the benefit way outweighs the risk, then we recommend it. Might be using terms like this is recommended or this should be done. Whereas the class 2 recommendations are where the benefit does outweigh the risk, but not quite so much. And so those might be worded as this is reasonable or may be considered. And then the class 3 recommendations are one for which there's either no benefit or harm. And so the wording, of course, depends on which of those categories. If benefit and risk are felt to be equal, that's usually listed as not recommended, whereas if risk is greater than benefit, it's usually listed as potentially harmful. So every one of those recommendations is accompanied by a class of recommendation. The quality of the evidence is then a separate categorization, and that has to do with what types of studies are supporting the recommendation. And we have A through C. A being high-quality randomized controlled trials or meta-analyses of such trials, all the way down to my favorite, which is level C, expert opinion, which is still supporting many of the guidelines, or level C, LD, which is limited data, typically observational studies and things that are of that nature. Just to give you a flavor of how much is being done with each category. This is from the 2025 guidelines. It's the distribution of class of recommendation in the top portion of this chart, and then the level of evidence in the bottom portion of this chart. We hope that this gets better and better every year, but I'll point out, for instance, that we do have 233 out of the 760 total recommendations that are listed as class 1, meaning they're strong recommendations. So roughly a little less than a third are considered strong recommendations on which we make these particular ones. And more interesting to me, though, is that only 11 of the 760 recommendations are supported by what we would call high-quality evidence, meaning randomized controlled trials or meta-analyses of randomized controlled trials. And this, to me, is the take-home message, which is we all still have a lot of work to do in the fact that a lot of our, even though we feel like it is a recommendation that's appropriate to make, a lot of our our stuff is still based on fairly low-level evidence, including about a quarter of it being based on expert opinion. So we want to see the numbers for A go up, the numbers for expert opinion go down, yet we still, I think, are happy to say that we got through making 760 recommendations and classifying them as is shown here. Thank you.
Thanks, Monica. So, no guideline is complete without a flowchart. So this is the algorithm for the ERC. This is the first time that we have managed to unify algorithms across pediatric life support, adult life support, in hospital and out of hospital life support. It's a relatively simplified step, so we check that somebody is unconscious or unresponsive. We call for help, and depending upon your setting, that may be slightly different. So obviously in hospital, you're not going to call for 112. You're going to raise the alarm by whatever means that is. So in the UK, in hospital, that might be by dialing 2222. It may be in some smaller hospitals, that just means shouting down the corridor for assistance. Opening the airway and assessing for absent or abnormal breathing, and then starting CPR. And you can see the differences in terms of the approach to CPR for both adult and pediatric. We also have the little QR code, so if people want to get additional information, that will take you to the actual guideline itself. And as soon as you have an AED available, switch it on, follow the instructions, and then continue with CPR until such time as EMS or the resuscitation team arrive, should you be in hospital. So that's kind of the overview of the ERC algorithm. I'll hand over to one of my colleagues just to talk through the AHA algorithm.
First of all, I love that concept that you've tried to bring everything together. So congratulations on that. Yes, sorry, I'm not good at holding a mic. Never was a singer or anything like that to get it. Yeah. Yeah, it's true. I know you wouldn't want that, I don't think. All right, so the AHA algorithm, we actually have one for healthcare providers and one for providers. Oh, this is the 2020.
That's my fault.
Okay. I was like, wait a minute, something doesn't look quite right here. But yeah, this is the 2020. We'll work on getting the correct one up, and then we will show you. Does that sound good?
I don't have access to it.
Oh, I do, though. Just give us a minute.
We'll come back.
We'll come back.
Yeah, we'll come back to the guide. If you want to
Yep.
move on to the other thing, I'll just put them side by side, just so that people can see them as a thing.
Okay.
Yeah. My apologies. That was me trying to, when I inherited this session from Janet this morning, I thought I had the correct guidelines, but clearly I don't work for the AHA, so I've dropped the ball there. Those are the guidelines. We'll come back when we start the questions just to display the AHA guideline as it was supposed to be. I feel awful for doing that. My apologies. So we're going to kind of move on to some of the key differences between the AHA and ERC guidelines. So what I suggest we do now in terms of taking those things one row at a time, so we'll deal with recognition first, EMS activation, looking at or the surface on which CPR is performed, and then moving on to adult foreign body airway. And we'll start with a brief discussion from our colleagues on the table, if that's okay. So I'll bring over the microphone and they can take over.
Okay, let's look into the difference between ERC and American Heart, and let's emphasize on recognition. So what we included in the algorithm now in the 2025 guidelines is the call early strategy. Directly after the confirmation of an unresponsive person, call the emergency dispatch center.
And I think that's a major change, major difference. And we didn't change anything from last AHA guideline from the recognition standpoint. So still our recommendation is when patients are unresponsive and then not breathing or has agonal breathing, then we call EMS. But I think the major difference in the ERC and AHA is in AHA, we still want to check the breathing, then call EMS. Instead, ERCs, and you said when the patient is unconscious, patient need an EMS call, just more higher care than just the call EMS. That kind of makes sense too.
Yeah, but in our opinion, is the call first will help recognition. If you look into the data, you'll see that a lot of cardiac arrest is dispatcher assisted recognized and not by the direct bystander. So that will be an improvement. We are now here in the Netherlands. We did it already earlier, maybe not well underpinned with science, but we more from a practical approach. And what you see in the data is that the amount of calls will not increase, but what you see, the recognized cardiac arrest will increase within the same amount of calls, because calling early means that maybe it will give a little bit more workload in the ambulance service. That was the idea or the suggestion, but you don't see that back. Most of the bystanders call in serious emergencies, and then an ambulance needs to be dispatched anyway. So that's about cardiac arrest recognition. Do we do questions already point by point or afterwards?
So just another couple of minor things from the ERC point of view. Some of the work that we did was underpinned by the ILCOR co-stars. So one of the pieces of work that Chris Smith in particular undertook was looking at how do we recognise unresponsiveness and how do we recognise that for that first encounter of cardiac arrest. And one of the groups that comes up as being particularly challenging are the professional sports people. They often collapse. They may still appear very much like they are responsive, very much like they are breathing, but they are in fact in cardiac arrest. And there are quite a few well-known, publicised sort of cardiac arrests that happened on the football field. So we've got increased emphasis within the ERC guideline that it can be very challenging, and there may be a period of seizures that precedes that in terms of the onset of cardiac arrest. With respect to the ERC change, obviously historically we were unresponsive patient with abnormal breathing, then call for EMS. We've now changed that sequence, so it's unresponsive patient, call EMS, and then assess breathing. And the primary driver for that was the ILCOR systematic review that looked at the interaction with EMS call takers, that identified that the vast majority of cardiac arrest calls are actually only identified at that sort of call stage rather than preceding. So moving the call forward means that we hopefully reduce time to recognition, and we get reduced time to first compression. So that was the primary driver from that. And as Sander has alluded to, we didn't perceive that there was going to be a substantial increase in call volume associated with that. That hasn't been borne out in the areas that have made that change, like here in Holland. And it's equally appropriate that we call EMS when somebody is just unresponsive as opposed to in cardiac arrest. So we don't perceive that there's going to be a substantial change in that respect. The other areas that we have where there's notable difference between the two, the first of those is the service on which we perform CPR. Now, ILCOR have undertaken a systematic review on this, and we've both interpreted this guidance in slightly different ways. So what we do know is that it is possible to do CPR on a soft surface. So you may need to compress harder to achieve that same compression depth, because you're also going to be compressing the mattress if they happen to be lying on a bed, but it is possible to do it. So the question becomes, should you leave on the bed or should you move to the floor? Now, we thought pragmatically, if you're moving to the floor, you're actually delaying time to first compression. So we're actually getting a more rapid sort of time to first compression if we stay on the bed. And whilst it's not necessarily an issue for the person who's in cardiac arrest, we also have to take into account the possibility of causing injury to somebody when they're moving somebody onto the floor, which may impact their ability to provide CPR. So we made a very pragmatic decision to recommend that if somebody does suffer their cardiac arrest on a bed, not to move them, but we acknowledge that the firm surface is the most ideal place on which to undertake CPR. And I think that the AHA will probably say they've got the same understanding, but they've just come up with slightly different wording. So I'll leave that to Tatsuya just to run you through those elements. Oh, Monica, sorry, Tatsuya was holding the microphone.
Yeah, no problem. I'm working to get the other algorithms up so we can hopefully share them here. I think we did have very much the same idea. We came up with a slightly different wording, which was to do it on a firm surface, and that could include moving a patient as long as it did not delay chest compressions. So we tried to get the best of both worlds, saying, yes, you should be on a firm surface. However, you should not delay chest compressions. So that could mean starting compressions on the bed, on the mattress.
Yeah, I think that's quite interesting that we've got the guidelines that are based on the same evidence, slightly different interpretations of the two that have resulted in slightly different recommendations. I think one of the things that guided us was we are trying to simplify this as much as possible for the lay responder, and if we say don't move them, then that's a little bit easier for them. Next, we're going to go and kind of discuss the foreign body airway.
Can I have just a small comment on the foreign surface? And we discussed this a lot from more in-hospital cardiac arrest cases, because most of the in-hospital cardiac arrest cases happen on the bed. And what is a practical way to do? I mean, still went to the same conclusion. And we discussed a lot from the perspective of using a backboard too, because it's been implemented in some hospitals, but not everywhere. So we had lots of discussion what is the best way. So that's why we said firm surface is preferred, but unless it's not causing any delay to the chest compression.
Excellent. Nice bit of additional information. So the other area where we have a notable difference between the ERC and the AHA guidelines is actually the ERC haven't included foreign body airway obstruction within the BLS guideline. And the reason for that is we wanted to try and avoid as much duplication as possible. And we thought it's entirely possible that you'll have somebody with a foreign body airway obstruction who is not in cardiac arrest, and they would be managed by somebody within the first aid chapter. So as a result of that, we have moved foreign body airway obstruction from the BLS guideline into the first aid chapter, because it deals with patients who are both conscious and in cardiac arrest. And at the point when they go into cardiac arrest, the treatment for that is much like CPR. It's going to be chest compression. So there's no significant change there, but we're aware that it's going to be a topical issue for many people. So we're going to address that first from the AHA perspective.
Good afternoon. My name is Tatsuya Nori. I'm an emergency medicine physician in the United States. I participate on ILCOR and task force member, but also I am the, as Monica mentioned, writing group member of the AHA BLS guideline as well. So I'm talking from the AHA perspective today here. Sometimes the guideline changes so quickly and it's very hard to follow. That is not the case in the foreign body recommendations, because we haven't changed the recommendation for choking or foreign body airway obstruction for 15 years. In 2010, we recommended abdominal thrust to be applied first. Then if that doesn't work, we said chest thrust might be considered. So that is a recommendation in 2010, but since then there are more evidence available, and we have done systematic review from ILCOR. So this is 2025 new guideline, new recommendation on foreign body airway obstruction. The biggest difference, as you can see, is now we recommend using 5 back rolls first. And I'm gonna have more background information the next slide, but essentially we are saying now back roll first, then if it doesn't work, then go to the abdominal thrust. So that's the first one. The second recommendation is rescuer should activate EMS and when patient has a severe FBAO. It's because sometimes the intervention we perform for foreign bodies cause some injuries to the patient. So they need to be seen by the higher care. And also, some of the patients need the higher care to get the foreign body out anyway. So we recommend call EMS as soon as possible. So that's the second one. The third one is for the mild foreign body obstructions, people can still speak. And we recommend the patients should be encouraged to clear airway by coughing. So that recommendation hasn't changed since 2010. Can go to the next slide. So this illustrates the reason why we made significant changes since 2010 to 2025. And as you might be aware, the ILCOR did a pretty comprehensive systematic review on this topic in 2010. And the coaster says back straps are used initially in adults and children. So now our AHA recommendations are consistent with the ILCOR coaster in 2010. But we also did a systematic review on actually together as a AHA work writing group, because 2010, 2020, and then now it's 2025. So we want to include more newer evidence. And what we found is on the 2023 and 2024, we have several observational studies, relatively big population-based observational studies, one from Japan and one from Canada. The one from Japan says prompt performance of appropriate intervention to relieve the FAO is associated with a good survival and a good neurological outcome. And the second one from Canada says, it's including 700 patients, showed the back blows were associated with improved rates of FAO relief compared to abdominal thrust, and with fewer injuries. So with this, and the other one, the systematic review included more than 52 cases of complication from abdominal thrust. We changed the back blows or initial intervention compared to abdominal thrust. So that's the kind of reason behind the major changes in foreign body obstructions. And this table shows recommendation for unconscious adult patient with an FBL. We didn't make any significant changes on the patient with an unconscious FBL. And essentially, we just want to make sure the EMS is called as soon as possible. And when the patient becomes unconscious, we recommend doing chest compression, because at that stage, the back row is almost impossible to perform. Also, abdominal thrust are almost impossible to perform when the patients are unconscious. So we didn't make any significant changes on this first one. And the second one is when the patient, when we open the airway for the CPR, when you see the visible foreign bodies in the mouth, you can take it out. But if you don't see it, you don't want to do the blind finger sweep, because can cause injury to yourself, but also can push the foreign body even deeper. So we recommend not to do blind finger sweep for these patients. So that's a recommendation for unconscious. So we put together just everything for the conscious patient with severe FBL and the patient with the severe FBL, but now become unconscious. So this is actually the first guideline, first algorithm for FBL in AHA guideline. So we want to make it very clear, and then we want to make it simple. So verify scene, then check signs for severe FBL, and if there's no signs of severe FBL, you encourage patient to cough, so that maybe patient can get the clear airway by coughing. And also you want to check the signs of FBL when you're encouraging patient to cough. If the patient become more severe FBL, you want to do back blows. Then if it doesn't work, the abdominal thrust should be followed. Then if the patient becomes unconscious, you do CPR. So it's pretty simple, but we put together to make it even easier to understand for lay persons. So we are going to more controversial area, and then we have very, very limited evidence around this. So this table has a few recommendations. The first one is, first two are more special situations with the foreign body obstructions. We have many patients with high BMI, obese patients, so sometimes very difficult to perform abdominal thrust. In that cases, we recommend chest thrust instead of abdominal thrust. But still, back blows are easy, so you do back blows for even patient with high BMI. Then if it doesn't work, you do chest thrust instead of abdominal thrust, because sometimes it's impossible to do because of the body habitus. The second one is the patient with late pregnancies being a topic, but we have very, very limited evidence around this because of the potential injuries to the mom and the baby. We want chest thrust should be performed instead of abdominal thrust in that case. But still, back blows should be done initially. Then if it doesn't work, chest thrust. The third one is more controversial, as you have kind of discussed already. Portable suction devices being tested and marketed. So the few studies came up, but when we did a systematic review, we still didn't find enough evidence to say this should be used as a standard of care. So we concluded there's a lack of evidence suggesting the superiority of these devices over the standard techniques like back blows or abdominal thrust. So for this, we don't recommend, essentially just says we don't have enough evidence to say we should do So that's the AHA recommendations. And actually going to an ERC, do you want to just briefly explain what we say from the ERC standpoint?
Hi, so I'm Jessica Rogers, just for my conflict of interest. So I sat on both the first aid and the BLS writing groups for ERC. So I've been asked to come and kind of cover this crossover slightly. So yeah, we used the same evidence. We had the same ILCOR reviews. We know that the evidence isn't fantastic for choking in general, but the gold standard we stuck to as per our previous ones we've got a nice infographic that I don't think we've got on this presentation, but have a look at the guidelines. We tried to keep it really simple, just like the BLS chapter did. We know this is mostly going to be for lay people looking at this. So we just take you very simply through the stick to effective cough, 5 back blows in a cycle with 5 abdominal thrusts until the person either you relieve the obstruction or they become unconscious, at which point we point back to the BLS chapter, the standard BLS CPR instructions. We also had significant conversations between ourselves and the paediatric group around the foreign body airway obstruction devices that are on the market. And again, we just came to the conclusion that there just isn't enough evidence there for us to be able to either say yes or no, you should be using them or you shouldn't be using them. There is a large body of work that will be coming soon. We've been discussing it quite a lot at this meeting, but there will be a large nodal review that ILCOR are undertaking between BLS, first aid and paediatrics that will be looking at choking and seeing if there is any more evidence out there now to give us better advice in the future. But as it stands, we don't currently have any good RCTs or evidence around the devices. So we've stuck to the gold standard, back blows, chest thrusts, and then CPR if they become unconscious. And yeah, we put a statement in there that ERC just followed the same ILCOR recommendation.
Thanks, Jess. Okay, so we've looked at some of the significant. I've gone too far. We've looked at some of the significant changes that have occurred, but there are some areas where we've had additional emphasis or we've had more evidence that can help inform those things. So what we've seen within the ERC is that we've had an increased focus on where people place the AED pads. So we know that there are problems with people placing in particular the apical pad, so that's the pad that sits underneath the armpit, in the wrong position. It's commonly too low or it's commonly too medial towards the chest. So making sure that the pad is optimally positioned to ensure that the current flows through the heart is quite important. So we've had new diagrams to emphasize that. We have, in addition, now got additional information about what to do when a bra is present, because we know that there are differences in terms of outcomes of survival between men and women, and one of the drivers between of that is men may be more reluctant to perform CPR on a woman for fear of being accused of inappropriate touching, and equally we know that there are challenges in terms of getting the defib pads in place when somebody may be wearing a bra. So the pragmatic advice from the ERC side of things is if you can get the pads in place without removing the bra, then by all means do that. However, if the bra is creating problems in terms of getting the pad in the right place with the right contact, then you need to do something about it. And if you can do that by just moving the bra, great. And if you can't, then you may need to cut the bra away to actually gain access to the chest in order to do that. And then we've also got additional advice about CPR in obese patients, which has already been touched upon. The evidence review by ILCOR showed that actually we can't really identify whether one method of CPR improves outcome, and we don't really know whether the outcomes are actually better or worse for obese patients. It depends on which study you look at. So some studies say that patients who are obese have better outcomes, and some say that they have worse. So because we don't have any clear direction, our recommendation is actually we just follow standard CPR for patients who are obese. I don't know if my colleagues from the AHA want to say anything in addition to what I've just said. No? Okay, fine. So just to recognise that there's significant changes between the guidelines. The ERC have obviously made this big change to change the initial process in terms of how we alert EMS. So it's now identify that the patient is unresponsive, then call and then assess the breathing with the intention that we increase recognition in terms of using the call takers to help identify cardiac arrest. So that's a very substantial change for the ERC that hasn't followed through with the AHA. And you'll notice within the ERC guidelines, those of you who have had a look, that we have an increased emphasis that identifies that if you're a woman, you're likely to have worse outcomes. So simple things like making sure that all of the victims of cardiac arrest are women is one of the most practical ways that we can address that. We've also made recommendations that mannequin manufacturers should make more realistic women, and we should have more appropriate body sizes as well. So hopefully that follows through to the manufacturing communities. We also identified that there are a number of sort of major research gaps. Notably, there's a proliferation of, or rather there appeared to be a proliferation of ultra-portable AEDs. Hopefully, that means that they're more available and they can be carried around more with ease. And as a consequence of that, we may be able to get more widespread application of AEDs. The challenge with all of that, of course, is that we don't yet have much outcome data. So many of these devices have got sort of marketing authorization. They are being sold, but we don't have any clear evidence coming through about how effective they are. Generally speaking, they are smaller devices, so they are limited in terms of the number of shocks that they can provide, which may have consequences further down the line. We've also got work emerging in terms of paddle size and placement. As we've seen in the previous plenary discussion, there was talk of should we be using dual sequence defibrillation, should we look at anterior-posterior versus anterior-lateral positioning, does the pad size matter? More recently, we're starting to undertake work within ILCOR about looking at should we be advocating that we shave the chest in terms of improving adherence. So there's quite a bit of work to be done in that sort of area. And equally, as has been alluded to now, we don't really know what's happening in terms of the foreign body airway obstruction. There is a big nodal piece of work going on within ILCOR about looking at whether or not these sort of suction type devices may improve outcomes. But as of yet, we don't have a clear picture. They certainly seem to work in terms of mannequins, but mannequins are very different to humans. And case studies aren't reliable evidence in terms of showing benefit of one type over the other. So just to kind of wrap up the hot topic areas that we've discussed, we've looked at, in terms of recognition, we seem to be missing a slide. I don't know what's happened there. Somebody has nicked a slide, so you're going to have to take my word for it. We're going to look at the topics that we've mentioned today. We've looked at recognition of seizures. We've looked at the change in process of, particularly from the ERC point in terms of activating EMS and the timing of those different steps. We've kind of discussed the firm surface and whether or not we should be moving somebody to the ground. Clearly, there's a slight difference in emphasis between the two guidelines. We've discussed more quite extensively, actually, the foreign body airway stuff. And we've mentioned about removing a bra and the sort of the value that working with AEDs can bring and the future in terms of ultra-portable AEDs. So in closing, I'd like to say thank you very much to my colleagues. I don't know if we've managed to get a copy of the AHA algorithm.
It is coming by USB any second now.
Okay, so as and when it arrives, we will put it up to correct my faux pas so that we can see exactly what the AHA algorithm is. But in the interim, absolutely, yeah, we'll build up because that'll make up for my error. We'll move over to if there are any questions from the room, and then we can start answering those, and then move on to those who are online.
Thank you very much, Bernd Böttiger. I'm from the ALS group. I'm very interested in what BLS is doing. I like the approach of the ERC to recommend for non-educated lay people only doing chest compressions. That is what I have seen. And then you said in trained lay people they should also ventilate. And I have two questions coming with this. First one is maybe, I don't know whether you know the IDRIS study showing that even educated paramedics were only able to deliver 2 successful ventilations in most of the patients in the out-of-hospital setting within 10 minutes. So even educated paramedics are probably not really skilled in doing ventilation. some are successful, but in most of the cases they are not successful. So I'm wondering whether lay people really, in a patient, not in a mannequin, in a patient really can ventilate. Children is probably a different thing, but adults, I doubt that most can. And if we then say educated lay people should ventilate, what does educated mean? I mean, we know that half a year after a first aid or CPR course, they more or less have forgotten most of the theoretical knowledge and maybe also of the practical skills. So I'm in favor of telling lay people in adults only to do chest compressions, and only if they are really totally skilled, meaning trained every half year or every 2 years, and are sure by themselves that they can ventilate, then they should ventilate, but all the others don't waste the time with ventilation. If an EMS is arriving, let's say, within 10 minutes, and if you're not in the International Space Station having to wait a little bit longer for EMS. Sorry, that's my question.
So I think you've probably had enough of my voice. Shall I give my colleagues a chance to chime in? And if need be, I'll quite happily give my 2 cents worth.
Well, yes, thank you, Bernd. Traditionally, we have ventilation incorporated for a long decade into the guidelines, and maybe there is a discrepancy or a difference between paramedics, but I'm a paramedic for a long time, and I go with you with the idea that ventilation is it's a difficult skill to manage, but maybe paramedics use difficult devices, and not talking about airway management, but also talking about ventilation. So if we bring it back to mouth ventilation, probably, which I will not see do my colleague paramedics, that would be an interesting, but I think that would be easier. And I think if I look into from an educational perspective in training, I see many successful CPR courses and lay responders getting air into the patient. Also, if I look into also mannequins, but we have with community response, we have a serious amount of practical experience and see. It's not studied probably, but I don't have. I think it's if we do a change and it's a big one, we need to have more evidence and more studies to exclude ventilations in the trained population. Then.
So my sort of take on this is I don't disagree with what you're saying. Certainly, the initial move to chest compressions only was because we knew that, in particular, bystanders, when they were taking telephone advice, struggled to understand and delayed time to first compression. So that's, I think, one critical aspect of it. I think we also know that certain types of cardiac arrest, in particular hypoxic cardiac arrest, will benefit from ventilation should they need it. So I think that we shouldn't throw the baby out with the bathwater. We should keep the option for ventilation within the guidelines. I agree entirely that there is a difference between ventilating the lungs. Essentially, if you've got a bag valve mask, you don't know what's going into the lungs and what's going into the stomach. So there is a difference between insufflation and ventilation. That, I think, still remains to be studied adequately. But I don't think we're at the point where we've got sufficient evidence to be able to say, let's just concentrate on chest compression only, because there's going to be some point down the line where the patient is becoming increasingly hypoxic, increasingly hypercarbic. Unless we do something to ventilate that, we're not going to change the outcome.
Thank you very much. But please, we need to recognize we have several studies, or at least registry data coming from Scandinavia and from other parts of the world, showing that there is no difference with regard to outcome whether lay people do ventilate or do not ventilate. We have a lot of data on that. So there is no difference in outcome between the question whether lay people, bystanders, did only chest compression CPR or did conventional CPR, and in what way is that recognized?
Well, the converse of that, if there's no difference, there's no harm in keeping ventilation in rather than dropping it out. And for the small population that may benefit from ventilation, it may be worth keeping it in there if we're not harming patients on a whole. That would be my interpretation of the question.
And this is probably not directly answering into your questions, but I love this topic. From ILCOR standpoint, we have two related peak costs happening. The one is almost finishing up. One is SGA, supraglottic airway, and device placement by BLS providers, because we know it's so difficult to do BPM even for the trained person. So I think we have one peak cost that's almost finishing up with a node of the ALS asking the supraglottic airway device placement by the BLS providers are good enough and efficient. I think that it might be answer to some of the questions. And the other one also happening is the real-time feedback ventilation device that's new and being tested in some other places. And if it's effective, then that might give some ways to improve ventilation. Still as paramedics, still EMS providers, not a lay person, but we are trying to answer some of the questions from the different angles too.
Mm-hmm. Maybe I would like to respond to your comment. If there is no difference between compression only and conventional CPR for lay people, then we can recommend ventilation. That was your conclusion. But I have to add, there is a difference between compression only and conventional CPR, because the lay resuscitation rate is significantly higher when they are doing only compression only CPR, because the threshold to start is lowered because they are not asked for breathing. So that means overall survival is probably better if we recommend compression only CPR, because more lay people will start CPR. That is the difference between both.
Yeah, I think that's a fair point. I mean, our guideline does say to start with chest compressions and only move to compressions with ventilations if the person is willing and able. So if they're unwilling or they don't feel that they're confident to do it, then they stay with just chest compressions.
Hi, my name is Pascal Cassin. I'm of the International Federation of Red Cross and Red Crescent. So we are teaching to nearly 30 million people per year, and effectively more for the lay public. And if the differences are minor between AHA and ERC, it's based on the same scientific consensus, and I think it is regrettable to because this difference between these two major partners, as these guidelines are read by many trainers, it probably confuse around the world the principle. We want to be simple. So that's just a remark. We can't change nothing. And for us, we will publish our guideline in a few weeks, and we're trying to be simple. But really, I think in the future, if we with the same consensus and science, I think it's regrettable to have even if it is small differences between big partners.
I take your point. I think there are some subtle differences between the two, and they're obviously using the same evidence, but equally, I think there is a slight difference in focus between the AHA and ERC guidelines. As I said at the beginning, the ERC took the pragmatic approach to try and make the guideline more accessible for lay responders who wouldn't have access to some of the skills that are catered for within the AHA guideline, and that may be one of the reasons why they are slightly different. But I think, if you looked at the basic steps and you broke them down, we're not recommending that you put your hand in different places. We're not recommending different rates. We're not recommending different depths of compression. So there's consistency there. They just may appear slightly different on the surface.
And I agree with Mike. And I think, thank you for the points. And with similarities standpoint, and I think that is a sign of success because one of the reasons forming ILCOR is to have guideline, the evidence available and systematically be global wide. In the past, before the ILCOR was formed, everybody was doing their own things, but now we have ILCOR, and we when we look, try to make the AHA guidelines, we often go back to ILCOR's coasters, and then we just reviewed some of the newer evidence since the ILCOR coaster was published. So that's one of the reasons both ERC guidelines and AHA guidelines are very similar or sometimes identical recommendations. So I think that's still the sign, like good things, I think, to make both aligned. And I think having this session itself is actually a good sign too, because this is probably the first time having the side-by-side sessions, so we can actually compare. Then we actually discussed a lot before these sessions, and we probably discuss more after the sessions too, because if we can actually make recommendation aligned, I think it's a good thing, particularly outside of Europe and outside of North America, because often people rely on these two guidelines, and if these two guidelines saying the different things, very confusing. But now I think most of the recommendations are almost identical, so I think that's a pretty good actually things.
Sorry. I've just been reminded that we've got the AHA algorithm up on the screen. So I'm going to hand back to Monica now that we've taken a sidestep, so she can talk you through the AHA algorithm. It's very pretty, I've got to say that.
Oh, thank you. So we developed, perhaps consistent with what is being said here, we actually divided our algorithm for healthcare providers and our algorithm for lay rescuers. I think perhaps it speaks to some of the themes that we're hearing, which is keeping it simple. And so the lay rescuer algorithm is definitely simpler than the other one that I'll show you, which is the healthcare provider. And so this we put in an infographic very similar to what was done for PALS. And so it is hopefully, I'm sorry, for PBLS, so it is hopefully more symmetric with them having both a healthcare provider. Oh, I got to get closer again. Thank you. A healthcare provider and then a lay rescuer. Is this a laser pointer? Yeah, kind of. I don't know if you can. Yeah, it shows a little bit. All right. So it's very much encouraging. And for the person who is unresponsive with no breathing or abnormal breathing, the recommendation is to activate the emergency response and then immediately start CPR. And the chest compression, of course, the chest compression symbol is there. The instruction being press hard, press fast in the center of the chest. And then this is applying the AED. This was a bit intentional. We originally had an arrow pointing here, but felt like it would be confusing to people to basically tell them to do two things at once. And so within the text of the guidelines, of course, it says to send somebody to get an AED. And then once the AED is there, follow the prompts and then resume CPR. I'll talk about naloxone in a minute, but this is intended to then just encourage the continual cycles of CPR. You can see this does not mention ventilations. If you look in the text of the guidelines, it says if you're willing and able, we recommend ventilations. And in part, that's because in the same IDRIS article, if you did get effective ventilations, as you know, survival with good neurologic outcome was improved. So even though it's hard to do, probably that means is we need better training, better devices, better ways to teach people how to do ventilations, like we've simplified chest compressions. In terms of the opioid antagonists, we decided to include this in BLS as opposed to make a separate algorithm for suspected opioid overdose. That was very intentional as well. We felt as though having an algorithm that said, if you suspect opioid overdose, do this, made it seem as though the rescuer had to make a judgment about whether this is a person who might have had an opioid overdose, which could lead to either assuming someone might have an opioid overdose or assuming someone might not have an opioid overdose. And so we put this in both of the algorithms for healthcare providers and for lay rescuers, that if it is a suspected opioid overdose, if naloxone is available, to use it. And this way, you're not trying to make a determination based on the setting you're in or the person's background as to whether or not they could be abusing opioids. Any questions on this or comments before we move to the other one? Yes, sir.
Thank you very much, Monica. Just one question or one comment. I think it's important to mention that the AED should not be taken by the person who is doing CPR, because CPR should not be interrupted. In that, having this in mind, my suggestion would be to put another person beyond the AED so that it is clear to every lay person that this is two different persons. Or maybe in my country we suggest that 2 or 3 people are doing CPR, and only if you have a third or fourth additional one, that he or she can take the AED. So my suggestion would be to put another symbol for a person beyond the AED. That would make it even clearer that it's not the same one, maybe even a different color.
Yeah, I appreciate that. I'm picturing like the running human, perhaps symbol as in a different color to go get the AED. I think I really like that suggestion. Thank you.
Copyright.
No copyright. Sorry.
So I have. Sorry. Can I ask another question or another comment?
Of course.
So I very much like the ERC approach. I have a conflict of interest because I'm ERC, to ask the dispatch center to help the lay people to check breathing or normal breathing or agonal breathing or something like this. I think this is a major step forward, and I'm really very much positively impressed about this, because in my experience, lay people always had, most difficulties they had is with checking for breathing. They recognize there's something wrong, but breathing, woo, what is that? Mm-hmm. Why is American Heart not following this path now?
So the BLS chapter does not take on dispatch-assisted CPR. That's in our Systems of Care chapter. And so questions such as the one you're asking are addressed in that chapter, but it is separate from this one.
And that may be where the difference is, because we very much have dispatch-assisted and tech-assisted built into the BLS chapter, and we intentionally did that and built it into every step to try and remove some of that differences between chapters. Did you have a comment on that before?
Yeah, so I think that's actually quite... Whereas the ERC tried to remove duplication as much as possible, so for example, moving foreign body airway and moving naloxone to first aid, we were of the opinion that the role of the dispatcher was so central to basic life support that we had the duplication, but that was just a local decision that we made, and the information is still within the AHA guidelines, just in a different space.
And just to make a note on naloxone, so this was another topic that was inherited into first aid for ERC instead of BLS. Again, there's not an awful lot of evidence out there at the moment around giving naloxone or not giving it, but we decided to include it and to have a look at it because we are very aware of the opiate crisis happening in America that we are now starting to see more of in Europe, and we are aware that there are now lay responders, children in high schools, who are now able to access naloxone and who carry it in their bags for overdoses in their school peers in some countries. It's likely that this may be coming to other countries before the next guideline, and that was a discussion we had, was that we didn't want to not include it, even though it's not super prevalent in Europe at the moment, because we felt it likely would be relevant within this next 5-year cycle, and we wanted to have some evidence out there. Again, it is limited evidence. We are doing an evidence update at the moment on this within ILCOR, and there are a few more studies starting to come out and some that are ongoing. So there may be some more evidence from ILCOR to come for this. But we decided intentionally, you decided intentionally to keep it in. We decided intentionally to split it and have a separate algorithm for opioid because it's not a huge issue within Europe at the moment.
Yes.
Fortunately.
America apologizes that we've been a bad influence. No, didn't say the word. Are you able to move forward to the second PDF that's on? It's a PDF, so I don't think I can do it with slides.
Smile.
Thank you. All right. So holding the microphone close. So this is the algorithm for healthcare professionals. That's also a term that has evolved. Of course, we've had providers and professionals and rescuers, et cetera, but healthcare professionals is now the term. And in this, we were a little more traditional in the appearance of the algorithm to the other AHA algorithms. But the first steps, of course, are similar. It does clearly say send someone to get an AED defibrillator in an effort to indicate that that should not be the person who's there looking at the patient. This could be a healthcare professional in a school. It could be a healthcare professional at the beach. I mean, it doesn't necessarily mean that you are in a hospital environment. Again, look for no breathing or only gasping, and simultaneously check a pulse. I think we all know that we're going to be questioning this, and in our lifetime, we may or may not continue to do pulse checks, but it is still here in the healthcare provider one. If you have a normal breathing and a pulse is felt, then you're monitoring. If you have a pulse with abnormal breathing, then you're going to begin rescue breathing with reassessment of the pulse every 2 minutes and starting CPR if you don't feel a pulse. And then if suspected opioid overdose, because this is basically respiratory arrest, then administer naloxone. For the patient who is not breathing normally and has no pulse felt, you're going to start chest compressions. And we recommend the 30 to 2 cycle, using the AED as soon as it's available. And once again, if there's a suspected opioid overdose, to consider the opioid antagonist. Once the AED arrives, it's applied. Shockable rhythms are shocked, non-shockable rhythms are not. And CPR is resumed until ALS professionals take over or the patient yells for help. We did put here this little footnote about what an adult is. If signs of puberty, treat as an adult. I know that that's something that those definitions are handled differently in different guidelines, but we were, again, just trying to make it super clear that this is intended for puberty and beyond. Happy to take questions.
I have a question. I have comment about the sequence of checking breathing and call help. First comment is in this algorithm there is an inconsistency because in the previous sequence we check breathing and then call EMS, but in this algorithm we call activate EMS and then look for the no breathing. So there is an inconsistency. And the second comment is about I think the timing for calling help, it depends on the situation, because for outpatient out of hospital situation, the advantage of calling help fast is we can have the dispatcher assisted judgment or help their assistance. But inside the hospital, when we call help, we need to know what we want to call. So if we don't know it is unconscious, only unconscious, or unconscious and no breathing, we need to apply for a different kind of resource. So is it a matter for in this algorithm? Is my question. Thank you.
It's not intended to be different. This is the situation in which you likely have more than one person available, and things can happen simultaneously rather than happening in series. And so the shout for help is hopefully bringing a person who can then be sent to activate the emergency response, while this person also is sending another person to get the AED, and then this person is assessing the patient. So it was not intended to indicate that you should wait until after you have assessed the patient to get more help for the patient, but it does recognize that there will be likely more than one person involved in the response with a healthcare provider. I know that's not 100%. My example is like a school or a beach where you may not have that. But the shout for help is intended to bring the people who you can then assign to get the AED and activate the EMS system while this person goes on, as opposed to the single rescuer who shows up and no help is coming unless they make that call.
I just worry about it. Because many people look very, very carefully about the AHA algorithm. So just they may be confused about the sequence in different algorithms. So just want to point out the inconsistency in that kind of expression. Yeah.
Yeah, I see your point. Thank you. I think this is one of those places where we have bowed to the difference in settings. In our effort, though, to address all settings, you're noticing that that means some slight differences in the algorithms.
I don't mean to avoid questions here, but I think we need to try and move. We've got sort of a couple of hundred people who are online as well to think about if we can answer some of their questions. So, Ahmed, if you can kind of pitch us some of the themes that are coming up and we can try and address those.
Yes, so we've got a couple of questions on AEDs. So one very specific question is about the presence of specific wording or direction if one should obtain an AED first if they are alone with the patient, with the victim. So if it's just yourself with the victim, would you start CPR or would you go and get an AED, basically?
Okay, so I can only speak sort of from the ERC perspective in that. So we have made it, so there is no clear evidence about sort of is there a time period within which if you can fetch an AED within 3 minutes, should you fetch it? If it's going to take longer than 3 minutes, should you stay on scene? We don't know that. The data isn't there to support that. What we have tried to do is make a pragmatic sort of recommendation. So if you are somewhere and you know there is an AED that is literally around the corner, then it may be worthwhile fetching it. We also know that if you're in, for example, in an office environment, if somebody collapsed here and I was to shout, hopefully somebody would come. So you have to make a kind of a pragmatic decision as to if you do, if you shout for help, is somebody going to come? And if they don't come, what are you going to do? And if you know where there is an AED that's very close by, it may be worthwhile fetching that AED, but only if you know, if it's like in line of sight and you know it's not locked, then it may be appropriate to fetch it. Otherwise, you may be better placed to start CPR, shout for help, and hope that somebody comes to assist. That's the ERC perspective. I don't know if there's anything different from the AHA.
No, I think that's another example of how it may be challenging to illustrate all circumstances in these algorithms. And as you saw from ours, the goal is to get them to start CPR right away, and then the AED is secondary. But it is whether there is a time beyond which one should say, I've done CPR for X number of minutes, nobody else is coming, maybe I should go get that AED. We just don't have evidence-based answers for that.
Yeah, I agree 100%, and I think just the concern is if that's one of the reasons we specifically say send somebody to get an AED, not to say, we didn't say getting AED, we just send somebody to get AED because the biggest concern is just the delay chest compression if you go to get an AED and then not doing chest compression.
I agree on that as well, but we need to mention that what we really know is that if we increase the time to the first shock, that will be beneficial for survival. So in that case, ook as a solo rescuer or solo bystander, just like Mike said, when an AED is available nearby, maybe assisted by dispatchers, because we have a lot of technology right now that the dispatcher can see the distance between the victim and the AED. Could be interesting, and I think I'm on the side that also a solo bystander can get an AED and then do a successful treatment in time. Thank you. Do you have another question, or is there anyone?
There's a few more. But
Yeah, I think call for help and also call EMS, and the dispatcher will guide. Thank you.
okay, can I go for another question here? Okay, so there's a question that's specific for the AHA about the material. The question reads, previously the videos, skills, checklists and tests had some inconsistencies. Is that going to be uniform now?
I can't answer without knowing specifically, but of course that is the intention. And we appreciate if people provide feedback if they find those as soon as possible.
Okay.
Thank you.
So answer is to direct that directly to HA for feedback.
Yes, please.
Okay. Awesome. Another question. So there's another question about ventilation breaths during CPR. There's a couple of questions. I'm just going to try and summarize them. So there was a mention of some studies documenting or reporting survival outcomes in both conventional and continuous CPR chest compressions. Do we know if there's any neurological difference? And based on that, should we recommend continuous CPR to save the energy and time delivering rescue breaths? That's a question.
That seems to have made its way back to me. I kind of defer to my earlier discussion with Bernd. I don't think we have any very clear information that there is a benefit of one approach over the other. I think we acknowledge that what the data that we have suggests that there is no harm from delivering ventilations. We know that when we can ventilate effectively, that neurologic improvement outcomes may be improved. And that comes down to a matter of training. There's still an awful lot that's unknown about ventilation, in particular with the advent of what's going to happen with sort of like ventilation feedback devices that may change the landscape. But I think for current times, if you are trained and confident in terms of delivering ventilation, I don't think that there is any harm in delivering ventilation.
Another question,
Please.
So can just it's very similar things, but that is exactly what the ILCOR, the most recent ILCOR says. It can be done both ways because we just don't have enough evidence to support the one way or another.
So another question is about pad placement and how to advocate for that in education. So question reads, can you speak a little bit more on anterior axillary pad placement for training purposes? How can we best instruct in the proper placement and explain the necessity during education?
Okay. So I think I think the one thing to bear in mind is that these are the guidelines. These aren't necessarily the educational materials. The educational materials will be supplementary to that, and obviously there will be an instructor who will enhance those educational materials. We've acknowledged within the guidelines, or rather we're aware within the guidelines of evidence suggesting that pads may be inappropriately placed. Usually that's because the pad is either too sort of medial and too anterior, and it needs to be shifted around. We've used better diagrams this time round to try and document where the pad should be placed. As a general rule of thumb, I would suggest that we probably need to suggest that it seems to be more to the side and more towards the armpit than the belly. Those would probably be sort of layman's terms in terms of trying to get it across, but that will be laid out more succinctly in the training materials and by the instructors. That would be my general advice.
Yeah, maybe that's also a nice example of what Pascal already mentioned, is that we have two good guidelines, and we have the same goal as optimized pad positioning. But if you look into the images in the new guidelines, we have different pad positions, specifically this pad here in the axillary line. So that's also for us a journey to learn to say, okay, how can we make the images look comparable, because I can imagine that will be a little bit confusing for the instructors. Say, okay, I see one image in the position vertical, horizontal. I think the good news is optimizing the pad position and have it in the most ideal line is covered in both guidelines. But yeah, it's always a way to improve.
Does anybody else in the room have any other hot topics that we can discuss? We'll try and do our best to answer. We've got another 10 minutes to go.
Yeah. Finn McNeil, and from the other side of the world. And this is more a comment than a question. We have some interesting insights on some of the things that you've raised here. Bridget here will tell you about the Good Sam app on a phone. That is a way of activating people near to a cardiac arrest. You're all aware of it. I presume you heard about it in your BLS session. There is, on the question of data on ultra-portable AEDs, the first trial, which is being conducted, again, Bridget, yeah, in New Zealand and in Victoria, which is a state that most of us disapprove. However, there is a trial which has finished recruiting, and I am told will report in November. I'm looking at Bridget. Yeah, right.
No pressure. No
But
pressure.
in ILCOR terms, soon rather than glacial. On the question of naloxone, we have a separate guideline on the administration of naloxone for Australia and New Zealand, and we have recently updated that guideline to include intranasal naloxone. There is no evidence of harm, not evidence of no harm, and we have mandated that teaching in what amounts to basic first aid courses. Now, not corporal shock, not awareness, but in the basic first aid courses, which is now regulated by yet another government authority. So with that, and you'll be getting a signal from the back and I'll shut up. But Bridget's happy to take some questions from the rest of you about all the stuff that she's doing.
Yeah. So I can speak a little bit to that in the interim whilst Bridget is getting herself psyched up for being ambushed. I think we wait with bated breath for the outcome of the ultra portable AED trial, because I think it's important. We don't really have enough data. I think it's important to recognise as well that a single study is probably not going to provide the definitive answer. I think that sort of if you get the chance to look at the ERC guidelines, we've embedded quite a lot of the information about the use of Good SAM apps. We're well aware of the technology and the value that it may add to that process. And it's one of the reasons why it's in both BLS and systems saving lives. I suppose the stuff about naloxone is probably going to become increasingly pertinent to most of us in other areas of the world. The US and Canada got to experience it a little bit sooner than we did. But, you know, that was another conscious decision by us to move it away from BLS to first aid, because equally you're going to have a load of opiate overdoses that aren't in cardiac arrest, and that'll be managed by that sense. And if it is in the context of cardiac arrest, that we thought that was probably more akin to reversible causes in terms of H's and T's, so probably more appropriate to the ALS scenario in terms of administering drugs. So that's kind of just the ERC take on those comments that you've just raised, Flynn. Thanks.
The first trial, hopefully we'll have some results probably actually slightly after Christmas, I think, depending on when the statistician has finished doing that analysis. In regard to Good SAM and responder apps, I think that's a really exciting area also for research in terms of how many responders do you respond, what's the ideal response distance for those responders, do they go into private homes, are they public? So lots of areas for research in that space and pretty exciting, I think.
And I think the ability to kind of dual dispatch some to the AED, some to the scene of the arrest to reduce the time to arrival of the AED, which kind of fits in with lots of the topics that we've been kind of touching on. So I don't want to say it's the future, but it's certainly one of the things that we need to consider. Certainly in the context of UK ambulance practice, it was we talk about response times of EMS, but actually improving outcomes from survival of cardiac arrest really depends upon the community response in the first instance. So it's the community that saves the lives, it's the EMS that brings the additional bells and whistles to kind of help progress it, but it's likely going to be the community stuff. I see Carolina is itching to come in and say something.
Just a quick comment that we have covered the volunteer responder systems and the systems of care chapter. So again, to avoid too much overlap, that has been covered in the systems of care chapter. Yeah,
that's a great point. Thanks, Carolina. We have 6 minutes left, so somebody's got to have a burning question or something come on online.
Only to add as well that yes, we did also cover some of the responder systems in BLS. We've only picked out here some of the real hot topics that we thought were some differences. There is more to the chapters than we've discussed here. So do please, if you've not had a chance, go and have a look at them, because there are other topics that we obviously haven't had the time to cover in this one short session.
We're passing the baton like it's a relay. If there are no further questions online and there are no burning issues in the rest of the room, we can finish 5 minutes early. Oh, were you about to say something, Matt?
Sorry, can I
Absolutely. Absolutely.
Maybe it's a ridiculous idea, but in children, we recommend they should also start check, call, and with 10 or 12 years compress, and later on then AED and ventilation. We have this in the System Saving Lives chapter in the European guidelines. Just a crazy idea, wouldn't it also be a good thing to think about, putting something on children as rescuers also in the BLS algorithm? My question. Sorry.
So,
Yes.
I think within the BLS guideline, we haven't really differentiated anything about how old a provider is. So, it could be that you've got an 8-year-old who is unfortunate enough to witness their parent going to cardiac arrest, and that we would expect them to be kind of following the same guideline that for an adult. So we don't differentiate in that sense. I think the one thing, you mentioned about the check, call, compress, that is within the BLS guideline as well. So we've tried to see some consistency between the pediatrics and basic life support, adult guidelines. Whether or not we need to make any recommendation within the guidelines about, a child of such and such an age can adequately perform CPR, I'm sat on the fence. I don't see a reason not to put it in, but then I don't see that there's any particular reason to put it in. We do have evidence that suggests that to perform effective chest compressions, you need to be over a certain body mass, which may be one of the things that feeds into that. But I don't know the honest answer to that. I don't know if any of my colleagues want to chime in on that, because I feel like I've been monopolising the discussion.
I just wonder, psychologically, for a child, say, under 12 or even 13, 14, to perform CPR, and like we know, out of hospital cardiac arrests, the majority of people don't survive. Is it too much to expect a child to be able to do CPR, and then afterwards, how are they going to feel? Okay, go.
But Bernd has good info on that.
But I'm not first. Maybe Carolina.
Yeah, Bernd, you can chime in. I'll bring this microphone down to Carolina.
we analyzed this question and we asked a psychiatrist, what is the right English word? A youth psychiatrist, or something like this. And we asked him for a statement exactly on this question. And we have put his statement on the website of the German Resuscitation Council because some people were asking us about this. We also have it on an English version on that on our website. And the conclusion is the children feel self-confident and feel better if they know what to do in case of cardiac arrest as compared to a situation where they don't know what to do. The problem is that children are confronted with the death or with an emergency, but this is the same whether they are knowing how to do CPR or whether they are not knowing how to do CPR. So if there is a trauma, that is not because they know how to do CPR, but it is because they are confronted with this kind of situation and you cannot avoid this. And they came better out if they know how to help. That's the bottom line of the statement.
Yes, I just would like to add, I completely agree with you, Bent. We've also looked into this. We have not studied children specifically, so that would be a good research question. But from a psychologist's point of view also, we've learned that what human beings find most traumatizing is actually not being able to act in the situation. So you cannot change the situation that the child, the teenager, is witnessing somebody dying. That we cannot change. But if you take away their opportunity to try and help, then you're actually really traumatizing them potentially. At least that's for adults. I can't imagine it's different for children. And our experience with training children is they feel very powerful and empowered to be able to help. So, but we should do a study on children. Yeah.
Thanks, Carrie. So actually, I was picking up the microphone to kind of just reiterate it. So, it may well be traumatic for a child to actually go through the experience of performing CPR, but it could be just as traumatic to not do CPR and for them to wonder, should I have done something? Could I have done something? With that, folks, I'm afraid we are now out of time. Thank you so much for your participation. I hope it was a useful session.